सो हाय गाइस, वेलकम टू द डॉक्टर्स इन डार्क। और आज हम बात करने वाले हैं एनीमिया, माइक्रोसाइटिक हाइपोक्रोमिक एनीमिया एंड इन दिस आयरन डेफिशिएंसी एनीमिया। तो सबसे पहले जानते हैं कि माइक्रोसाइटिक हाइपोक्रोमिक एनीमिया के डिफरेंशियल डायग्नोसिस कौन कौन से हैं। तो इसको बहुत इजी तरीके से याद रखा जा सकता है। इट्स एक्चुअली शीतल, बट वी कैन यूजुअली रिमेंबर विथ दिस निमोनिक्स सीता. S for sideroblastic anemia, I for iron deficiency anemia, T for thalassemia, F for anemia of chronic disease, and also L for lead poisoning. But that is not much important. So हम जानते हैं आयरन डेफिशिएंसी एनीमिया के बारे में. सो आयरन डेफिशिएंसी एनीमिया इज द मोस्ट कॉमन न्यूट्रिशनल डेफिशिएंसी एनीमिया. Iron absorption is done in the form of Fe plus 2. Fe plus 3 form is for the transferrin form or transfer of the iron form. Site of the absorption of the iron is duodenum. Two types of iron, heme iron and non-heme iron. Heme iron is present in non-veg and easily absorbable, and non-heme iron is present in vegetables or veg patient, and that can in the form of Fe plus 3, which is converted into Fe plus 2, and then Fe plus 2 form is absorbed by the divalent metal transporter 1, DMT1. Now let's see the factors affecting the iron absorption, and that is increased by vitamin C, citric acid, amino acid, HCl, and acidic pH, and decrease iron decrease iron absorption by alkaline pH, milk, phytate, tannate, and tea and coffee. So let's see the way to promote the iron absorption or patients which whom you advise to take iron supplementation, and with these precautions like eat vitamin C rich foods like lemon, bell peppers, tomatoes, oranges, cabbage, etc. Use ironware, means prefer cooking in ironware, so add more iron into the meals. Limit the caffeine, avoid the having tea or coffee, or less taking tea or coffee. Include lean meat. If you are non-vegetarian, then you can advise the patient. If patient is non-vegetarian, then you can advise the patient to take lean meat and pair vitamin A. Include vitamin A foods like carrot, papaya, broccoli in the diet to boost the iron absorption. Now iron absorption in intestine, DMT1 यानी कि divalent metal transporter 1 do not transport Fe plus 3 because it is specific for divalent cations. Hephaestin and ceruloplasmin converts Fe plus 2 into Fe plus 3, and thereby which the Fe is converted into transferrin and ideally transfer into the blood and reach to the tissue. ITF यानी कि iron transferrin can bind with 6 molecules of Fe plus 3. Blood transferrin can bind with only 2 molecules of iron practically, and that leads to the transferrin saturation of 33%. Now see, in the duodenum, the heme iron is directly absorbed in Fe plus 2 form, heme oxygenase, and Fe plus 2 form is go to the hephaestin or ferroportin and convert into Fe plus 3 and go into the blood capillaries and circulation. Iron delivered to the tissue or stored. But non-heme iron is in Fe plus 3 form, which is converted into the Fe plus 2 by DCYTB, and then it is divalent metal transporter 1. We transfer it into the duodenal enterocyte, and then via this enterocyte is converted into ferritin, the storage form of iron, or Fe plus 2 is go into the circulation via transferrin and reach to the tissue or stored in the liver. TIBC is total iron binding capacity. TIBC, unsaturated iron binding capacity plus serum iron. In bone marrow, 90% of synthesis of heme is in mitochondria and 10% of synthesis of heme is in cytoplasm. Endosomes acidifies and dissociates the iron and transferrin. DMT1 also present on the membrane, which helps in escape of Fe from the endosome. So any abnormality and DMT1 can cause iron deficiency anemia. So let's first read and then understand. Transferrin receptors are more on the surface of early erythroid precursor than late normoblast. It suggests that in mature RBC there is a less transferrin receptor, but in the immature RBC or reticulocytes there are more erythroid precursor transferrin receptors which transport the iron. TFRC release increase the serum transferrin receptors, and serum transferrin receptors are marker of erythropoiesis. It means serum transferrin receptors are increased, then erythropoiesis is increased, and serum transferrin receptors are decreases, then erythropoiesis is decreases. It depends on the erythropoietin. Now let's see. Now understand TF bound Fe uptake. This FeTF is bind to the two Fe plus 2 molecules, then it transfer into the endosomes. In endosomes, Fe plus 2 is converted to Fe plus 3, or Fe plus 2 is directly go for the utilization in the mitochondria or go for the Fe proteins complexes and other protein formation. एस्कोर्बेट या विटामिन सी इज इंक्रीज द Fe+2 एब्सॉर्प्शन. सो इस तरीके से अगर आप देखें तो DMT1 और ZIP8 और 14 मॉलिक्यूल है जो कि Fe+2 को एब्सॉर्ब करते हैं. स्टोरेज फॉर्म ऑफ द आयरन इज Fe फेरिटीन एंड एक्सपोर्ट वाया FPN1. और इस तरीके से हम देख सकते हैं कि आयरन टोटल ट्रांसफर, इस तरीके से हम देख सकते हैं टोटल आयरन bind to the two iron bind to the transferrin, but the capacity is 6 molecule of iron it can transport. अब देखते हैं आगे. हेप्सिडिन. हेप्सिडिन इज द मास्टर रेगुलेटर ऑफ आयरन मेटाबॉलिज्म. उसका सोर्स है लीवर, मतलब लीवर द्वारा हेप्सिडिन प्रोड्यूस होता है और उसका फंक्शन है कि वो इनिबिट करता है आयरन एब्सॉर्प्शन बाय इनिबिटिंग फेरोपोर्टिन and acts as a negative regulator of iron metabolism. Gene regulating hepcidin is HFE and HJV जो कि हीमोक्रोमेटोसिस के लिए रिस्पॉन्सिबल है. और फेरोपोर्टिन देखते हैं तो फेरोपोर्टिन इज प्रेजेंट ऑन प्लेसेंटा, डियोडिनल सेल एंड मैक्रोफेजिस ऑफ बोन मेरो. उसको नर्स सेल ऑफ बोन मेरो भी कहा जाता है. क्लिनिकल फीचर ऑफ द आयरन डेफिशिएंसी एनीमिया बहुत ही ईजी है. एज एन एनीमिया फीचर ऑफ ऑल आर सेम to the iron deficiency anemia or any other anemia. It's fatigue, spoon shaped nail. It means कि change in the shape of the nail, कोइलोनाइकिया जिसे कहा जाता है, एंगुलर चिलाइटिस और स्टोमेटाइटिस, पाइका एबनॉर्मल डिजायर टू ईट सब्सटेंस दैट यूजुअली नॉट इटन. मीन्स चाइल्ड बहुत ही इजीली कुछ भी चीज़ें खा लेगा, लाइक पेपर और लाइक टॉयज एक्सेट्रा. Important clinical feature is Plummer-Vinson syndrome, the triad of Plummer-Vinson syndrome, also known as a Patterson-Brown-Kelly syndrome or also known as a sideropenic dysphagia. इसका ट्रायड है डिस्फेजिया, आयरन डेफिशिएंसी एनीमिया एंड इसोफेजियल वेब. तो इस तरीके से ये अगर ट्रायड दिखेगा तो इसको बोला जाता है प्लमर विंसन सिंड्रोम. और भी उसके सिम्टम्स है लाइक चिलोसिस, ग्लोसाइटिस, इसोफेजियल वेब्स, आयरन डेफिशिएंसी एनीमिया. These are the symptoms of the Plummer-Vinson syndrome. Or diagnosis of the iron deficiency anemia is done by following lab reports: RBC indices. In RBC indices, there is a decrease of hemoglobin, RBC, MCV, MCH, and MCHC, and there is increase in red cell distribution width or N-isocytosis. In peripheral smear, N-isopoikilocytosis or pencil cells are seen. Microcytic hypochromic anemia, Pessary cells or leptocyte, and iron deficiency anemia can show reactive thrombocytosis. In N-isocytosis, there is a different size of the cells that can be seen. It means if you can compare it with the another smear of normal RBCs, there is a different type of the RBCs can seen, but the shape of the RBCs can be maintained if it's an isocytosis. And if poikilocytosis, there are different shape of the RBCs can be seen. So in iron deficiency anemia, there is an isopoikilocytosis is seen. It means different size and shape of the RBCs can be seen. In iron studies, there is a decrease of serum iron and serum ferritin. Serum iron and ferritin, and increase in total iron binding capacity, free erythrocytes, protoporphyrin, and erythropoiesis. In count normal in iron deficiency anemia, and bone marrow study suggests that bone marrow biopsy with Prussian blue is the diagnostic. In normal values of serum iron is 50 to 150 milligram per deciliter. Transferrin saturation is 50 to 15 to 50%, and total iron binding capacity is equal to 300 micrograms per deciliter. Now we can see the stages of iron deficiency anemia: stage 1, 2 and 3. Stage 1 is ferritin decrease and stage of decreased storage. In this sense, the store of the iron is decreased and it can be empty in stage 2. So serum Fe and ferritin and transferrin saturation is decreases, and total iron binding capacity and erythropoiesis is increases. In stage 3, peripheral smear can be seen, and peripheral smear changes can be prominent, and that confirms the iron deficiency anemia diagnosis. In treatment of iron deficiency anemia, iron supplement can be given. 100 mg iron plus 500 mg folic acid is seen in adults. It can be seen in lactating mothers is 60 mg iron and 500 microgram folic acid. Also given to pregnant woman 180 days iron with 100 mg iron and 500 microgram folic acid. The best indicator for the iron susceptible or iron sensitive treatment is reticulocyte count present at 5 to 7 days. If reticulocytosis or increase in the reticulocyte count, it means the response of the आयरन सप्लीमेंट्स इज़ गुड. तो ये था हमारा आयरन डेफिशिएंसी एनीमिया. थैंक यू, हैव अ गुड डे. एंड अगर आपको हमारा चैनल अच्छा लगा हो तो प्लीज़ सब्सक्राइब द चैनल डॉक्टर सेंडार.